Good afternoon, friends. We are honored to have with us today Dr. Gilada, a globally acclaimed HIV expert and the longest-serving HIV medical expert who started India's first HIV/AIDS clinic way back in 1986, if I remember correctly. Dr. Gilada is Governing Council member of International AIDS Society and he is President-Emeritus, AIDS Society of India. Welcome, sir.
Thank you. Thank you, Shobha.
Sir, you have said, and rightly so, that we can end AIDS as we have the tools to make that possible and to make undetectable, equal, untransmittable a reality in the lives of every person living with HIV. But where are we failing? Has HIV prevention taken a backseat? Your thoughts on it?
Basically, if you look at, we are weak in first 95, and that first 95, if you are weak in first 95, you will be always weak in second and third 95. Secondly, when we go from education awareness and intervention to treatment and viral testing, viral load testing, it doesn't mean that the previous two options should be ignored. And that's what has happened in national program, that we have totally ignored the aspects of prevention, which was at forefront. However, some part of that is taken care of because is the treatment as prevention, particularly in conjugal relationship. If one partner is positive and treated, that other partner doesn't get infection. So in that sense, we are able to prevent. But in larger prevention, we have been failing. And in the prevention, first part of this 95, there are a couple of things which are required, which we have not done. Number one, we are providing free treatment for ART, and that is for lifetime. But we are not able to give pre-exposure prophylaxis. That means if somebody can prevent HIV infection by taking PrEP, which is not part of the program, that means you don't allow the person to take PrEP and you allow the person to get HIV and then you treat for life, which is not even a good economics and a good policy statement. Secondly, when you allow PrEP, condom is also PrEP. It's a pre-exposure prophylaxis, but it's a prophylactic tool, and this is the chemical PrEP, so which is a medicine. So if you allow condom, why should not we allow PrEP? Secondly, home testing is not allowed. So there are some population currently what we see that 70% of the new infections are in stigmatized population. In those population, if you don't allow them to have a self-testing or whatever tools are possible, then you are not able to catch them when they are already infected or getting infected. So in that sense, we are already eliminating that kind of population, and therefore we still see a lot of people, young people, getting HIV infection. And lastly, we done a unilateral program of only HIV control. We never bothered to look at other STIs, sexually transmitted infections. So what has happened, as a gift of PrEP and PEP, we told people that okay, if you get exposed, then you take PEP. If you don't want to be exposed, you take PrEP. But that PrEP or PEP is in addition to condom usage, is not emphasized. So there are two sets of population which is working in the field of HIV. One, those which have the background of sexually transmitted infections, they know the importance of condom, and they will never tell people that okay, it's okay to take PEP or PrEP, but do not talk about condom. And there is a population of medical caregivers who have no exposure to STIs. They do not understand that, and they will talk only a tubular vision approach, and therefore we are still getting STIs, and because of STIs we are still getting HIV. So in that sense, what is happening is that India, being a conduit of supplying or conduit or even a supplier of 92% of the world's HIV treatment, so something will be made in India. Rest of the world will be free of HIV, and in India will be still having HIV issues. So, for example, for PrEP, whatever medicine is required, same is required for a PEP also, which is a basic PEP, not advanced PEP. So one can cheat people, go to ART center, tell that I am exposed, I want PEP, and get a PEP and use this as a PrEP. But the person is honest and goes that I want PrEP, PrEP is not allowed. So under that situation, what will happen? India will keep on making all the drugs which are available in all the platter, supply all over the world, all over the world will control HIV in a very good way, and India will still continue to have HIV infections. And that is not again a good science.
You're very right about that. Also about STIs, that other STIs are taking a back. They are in the background, not in focus. HIV is also one of the STIs, and so we have to put equal focus on all of them. I think you're very right there.
And two of the STIs are making a very big comeback.
Yes.
Hepatitis B and HPV, they are going to
Yes.
lead the next 10 or 20 years.
Yes.
The number of deaths which will occur because of hepatitis B will outnumber the deaths because of HIV, tuberculosis, and malaria together. And that is prevented through a minuscule cost of hepatitis B vaccine, which we are not providing. So at all the levels, we are testing people, which is called triple S testing. Before surgery, in hospitalization, in all the kind of transfusion associated services, you do triple H. If somebody is found hepatitis B negative, you don't even tell that person that you should take hepatitis B vaccine, or you don't provide them at AMC clinics or in blood banks or in emergency clinic. So if you don't prevent that opportunity of that person who has come to you for helping someone or helping self and for being found hepatitis B negative is not prevented. HPV is a costly vaccine, but you have to prevent. Otherwise, HPV is a killer disease. Sometimes women can get cervical cancer, men can get perianal cancer, penile cancer, and there's a one good study of Tata Cancer Hospital which shows that more than 50% of the oropharyngeal cancers are because of HPV. So people don't understand that oral sex is, earlier we used to call the safer sex, but even that is not safer. Maybe it is safer for HIV, but it is not safer for other STIs. And people will keep on getting HPV, either oral sex or anal sex or vaginal sex, and it will keep on spreading to others. Again, it is a vaccine preventable.
Yes, right. And as you said, that India is something like the pharmacy of the world, producing the medicines, and we have put a lot of our people on on ART also. But if we look at the loss to clinic, viral load monitoring, viral load suppression, I think there are huge gaps still. And how can we do better on long-term HIV care outcomes? Because it is just not enough, or you are the best person to see that. It's not just enough to provide the treatment, but ensure also the treatment is working and they are becoming virally suppressed.
You see, when people talk about long-term survivors, I consider there are three type of long-term survivors. Those people who are with HIV and on ART, those people who are with HIV and elite control or viremic control are not on HIV. So this one group. Physicians like us working in the field of HIV for 30, 35, 40 years. And there are pharma companies, a minuscule 4 or 5 of them. They are involved in the ART work, the ART production for 30 years. So if these three long-term survivors, they do not have good kind of cohesiveness, there will be problem. So when patient come to us, we should also tell them that it is in their interest to be adherent. It is in their interest, in their family's interest, in their wives or children's interest to be adherent. If they don't, then they will be facing a problem. Sometimes when you're providing everything free, people have no value. So you need to emphasize that out of 3, 4 things which are required, you are getting 2 things free. But at least adherence, which is again free from at your end, be adherent. So that adherence is required, and we need to emphasize. But at the same time, sometimes what happens, viral load is done, but viral load reports are not immediately available. A patient is going to come, the person living with HIV is going to come after 6 months. After 6 months, if you come to know that viral load is high, then that person was on 6 months virally unsuppressive medicine, and he will continue to do that, or she will continue to do that. So we are knowingly harming, and there is no mechanism where person's viral load is high, that person has been called. I have repeatedly asked patients that if viral load was high, did you get a call? No call. So if that call mechanism is not there, if you are not able to provide testing properly or reporting properly, you are not doing CD4 count. In between, you should have also doing CD4 count. There are people who will be immunosenescence. CD4 is not increasing. Viral load is suppressed. But CD4 is below 200, that person can get viral other infections, particularly fungal infection like Candida, tuberculosis, PCP pneumonia. So on one hand, you will control HIV, but on the other hand, the person is getting other infections. So we need to have a proper monitoring. It cannot be if and but. It cannot be said that we cannot afford all these things. If we cannot afford, we should not do free ART. Then there should be three-tier type of pricing. But if we are able to do that and we tell the rest of the world that we want to be part of G7 or G8 countries. So if we want to be part of that, then we, from all angles, we should be part of that. We cannot say that only in this aspect we will be part of G8 or in this aspect we are poor, gullible country. We cannot do that.
Yeah, you're very right, Dr. Saab. And what are the top key lessons you would like to share with other public and private centers regarding viral road suppression? Because your hospital, Unison Medicare and Research Center, is taking good care. It is setting an example for others to follow this aspect very clearly and properly, that you're not just putting them on treatment, but ensuring that they are virally suppressed. So, what would you like to tell the others?
When we say that we are good at viral suppression, we do not boast that we get 100% results. Black sheeps are everywhere. Some people do not take whatever you have been doing. So what we have started doing two or three things. Number one, any person who is on ART or following with us for 25 years, even pre-ART era, and they come for 25 years, we cut their cake, saying that is a 25-year celebration. When that cake cutting is done, whoever patients are there in the clinic, they all attend, all the staff attend. And we give a pep talk for that person, that how that regular that person has been, how inspiring that moment is. And at the same time, that person is allowed to also speak what difficulties that person has gone through. See, today, if you talk about ART and the young generation of doctors, they are getting everything on silver platter. It's a very simple ART, 3-in-1, robust medicine. You don't have to even look at again and again. But we, those practitioners who had started with one drug, two drug, three drug, you give one drug, it was like a system of a monkey. Monkey was going 10 feet up, 5 feet down. You start suppressing viral load, the patient is getting anemia because of AZT. You start doing something, patient was getting buffalo arm. So all these problems we face. Now we know that medicines are stable, simple medicine, very now when you start giving lot of facilities, then patient also expect lot of things. Some patient used to come and say that I cannot swallow this medicine, but all these years the persons were taking 15-20 medicine. Now you are giving one medicine, patient said I cannot swallow. So I give them very simple solution: take one tablet, eat banana, it will go inside. So we have to sometimes tell them, we have to also ask. For example, after the DTG has come, we come to know that a lot of people were not adherent because of the adverse effect of efavirenz. And efavirenz caused so many adverse events. At that time, patients used to come, used to say that this is the best medicine. We cannot do anything beyond that. We cannot afford some of the other medicine which are either multi-tablet or expensive. So if you and me or anybody who is cutting off the person who is coming with some problem, saying that no, this is the best medicine, the patient will not come back. Patient will come back after 5 years saying that no, I stopped taking that medicine. I was getting bad dreams. I was getting madness. I was irritable. I could not concentrate on work. Sometimes patients were not even told when to take that medicine. Taxi driver by profession, if I tell take medicine at night and that taxi driver is driving taxi at night, then he's taking medicine, he's driving taxi, making accidents. So lot of issues were there. Now things have become simple. So we need to put also onus on the person who is suffering from HIV or having HIV. Secondly, the entire AIDS term has to be taken out, because you don't say that somebody has got pneumonia and pneumonia with pneumonia as a coma. Coma is the end stage. Similarly, in HIV, AIDS is the end stage. HIV is only an infection, HIV positive status, HIV disease, AIDS, and death. Initially, that was a one-way traffic. Now, after the advent of good ART, and even before that also, there's a bilateral traffic. Even a dying patient is reverted back to HIV and remains so for whole another 25-30 years. Third thing I have started seeing, that in a set of people where there is a discordance, one partner is positive, other is not. You are following that positive person very regularly. So I know here's all the spare parts of the body: liver function test, kidney function test, cerebral nervous system, CVS, everything. But I do not know what is happening in the partner. If I tell the partner to do any testing, they say, no, मुझे तो कुछ हुआ ही नहीं, I don't have anything. Now, in materialistic life, what has happened? That a computer costing 30,000-40,000, you have annual maintenance contract. Air conditioner costing 30,000, you have annual maintenance contract. Car costing 5 to 10 lakh, you have AMC. But body costing crores, there is no AMC. So we started losing people who are HIV negative, relatives of HIV positive person, either a spouse or a brother or relative which were younger than that person, and we started losing them. So we started telling these people that look, today having HIV and being on treatment, a good ART is better than not having even HIV. And that's what we have been successful in telling 2-3 things. Number one, 100% prevention of partner to partner transmission. So what has happened with that? Though legally it is not allowed to have a HIV positive, HIV negative marriage. But if two people are marrying with consent of each other, with full understanding, no one can stop them. So we do not force anybody to marry as HIV positive negative, but they come for counseling. And they say that, doctor, you are telling that undetectable is untransmittable, untransmittable is zero. So we can marry, we can have a child. So I do not get HIV, I do not pass on HIV to the child. So when you argue separately, they say that today I know that this person is positive. What about the other person whom I don't know whether he's positive or not? There's nothing like a pre-marriage testing. There's no history available. So at least for even a conjugal relationship, the person's HIV status known as HIV positive on treatment is better than non-HIV. Lastly, I can provide them that with HIV, your lifespan is not reduced by 1 day. So if people in India are born at birth, the average lifespan for male is 71, for female it is 73. Even if HIV is diagnosed at the age of 20 or 25, I can guarantee that the person will reach 71. Now with my age, I started telling that when you come back after 10 or 15 years, I may not be there, but you will be there. You will not die of HIV. You will not be admitted because of HIV. You will not transmit HIV to your wife or spouse. You will not transmit HIV to your child. And there is no discrimination required in your financial life, your physical life, personal life, anything. So that has, even sexual health counseling has become very much regular part of that. Lot of time we, because of shyness is not only between few people, it is also between patient and doctor. So we started putting additional questions to them. Do you have sex or not? No, that previous doctor told us not to have sex at all. So what happens? If there's one person is positive, other is not, that other person who is not having HIV infection may have sex with somewhere else. So that way we are seeing that other person because of lack of counseling. So counseling has to be part of good life, sexual life, physical life, financial life, and that good kind of planning should be there. And we need to also tell that if you are getting medicine from government, fine. Even if you are taking in private, you see that you earn more than what you are spending. So if suppose somebody is spending 5,000 a month and earning 3,000 a month, by living, that person is minus 2,000 per month, it is not worth living. You should earn more than that. So my job is to see that the person is up and running, not admitted in hospital, not spending elsewhere, and avoiding hospitalization is the most important thing in HIV practice. Otherwise, once somebody gets hospitalized, within a week, that person keep on end up spending 2 to 3 years of total cost required for ART. And that's what the hospitals have become so expensive. And we have so many issues with hospitalization. So I think we need to do that kind of comprehensive way of management of how to manage patient on a outdoor basis.
Thank you. Coming to TB, you had mentioned that earlier that when the CD4 count supposing is less, then the person is prone to so many infections, and TB again, even still, it is the biggest killer of people living with HIV. So in the general population, WHO and national TB programs, they are calling to screen everyone for TB, say with X-rays, and now we have portable X-rays available, so that the TB surveys have also showed that I think more than around 50% were asymptomatic. Now, is that being done in the case of people living with HIV? Are all of them being tested for TB, or they are being tested on the verbal screening is being done only there?
You see, as a protocol, every 6 months or at least once in a year, we do X-ray test of every person who is coming on ART follow. So that way we avoid not only tuberculosis, but sometimes bronchial asthma or PCP or any other chest-related phenomena. Secondly, doing testing for everybody, doing screening of everybody in the population is a wishful thinking. The moment we say that, the government will take a backseat. So we need to go in a stepwise fashion. Number one, if you are talking about vulnerable people who can get tuberculosis more often than others, then all PLHIVs are in that. In that kind of population, we should have a urinary lab test. Now, unfortunate part is urinary lab test is available only for research. Last 4 years, 5 years, we have been waiting that urinary lab will be made available in common market. It is not happening. The innovators are willing to give that. So I don't know where it is stuck. So something which are simple to diagnose asymptomatic tuberculosis, it should be done without even person's involvement, not doing any kind of test, just taking urine and doing urinary lab test. So that is not happening. Secondly, I remember almost 30, 40 years back when I joined JJ Hospital. That time there used to be a MMR, mass miniature radiography. The van used to go in crowded places and do MMR and find out tuberculosis, particularly in a slum population like Dharavi, etc. Now we are 40 years ahead of that. There are a lot of AI tools. There are a lot of facilities available. Particularly in a family, if somebody is positive for tuberculosis, you should be able to diagnose other and screen other members of the family. And it is possible that 20 to 25% of the family members could be already infected. So in that case, the positive yield is high when you are doing in a population which is the catchment population. Secondly, extrapulmonary tuberculosis is also important, but fortunately that is not infectious to others. So even if somebody has a TB gland or somebody has abdominal cox or somebody has a brain TB or bone TB, that is not infectious to others. So, but for the person, it is important. So in that sense, we need to also expand, because a lot of time people think TB means only chest. We need to tell people that TB can be any part of the body can be affected by tuberculosis. So we need to also expand that, and we should be able to diagnose. And lastly, TB prevention or TB prophylaxis. See, as I stated earlier, India is one country which makes any kind of drug available at pittance of the cost. Rifampicin INH combination is made by only one company in India. That company is providing to the 92 other countries in the world. But it is not available in open market for last 4-5 years. That company's entire stock of rifampicin and INH expired, and we were sitting on it. And Honorable Prime Minister declared on 24th March 2023 that this will be made available. Now, in last 3 or 4 months before I went to a committee meeting in NACO, they said that it will be made available. But I have not seen any person who got it. So I don't know where are we stuck. So there has to be a good cohesion between the pharma companies, the clinicians who have experience, the Food and Drug Administration or CDSCO, Government of India, and Health Ministry. And Health Ministry and CDSCO, they are in the same minister, same Health Secretary. Where are we stuck? Fortunately, this time, the Health Minister is also Minister for Chemical and Fertilizer. So even raw material in charge is also same Health Minister, Dr. J.P. Nadda. So in this situation, I always appeal them that do not consider as an adversary. We are also equal patriot like you are. We may be less than you if you think so. But we also want to save our people. We also want to see that the things are made, provided, which are at pittance of the cost. And rather than giving 180 days of INH, if somebody can get rifampicin INH combination once a week for 12 weeks or once daily for 1 month, why not to give that benefit? And that is made available in the country. As it is, there are a lot of companies are not interested in making tuberculosis medicine available. So, because there is a DPCO, Drug Price Control Order, and they always control the drug prices. Now, if you look at the supply or medicine supply from India, you compare it anywhere in the world, the packaging is similar, the product is similar, the content is similar, the purities, impurities are similar. How that will cost pittance? but we are not keen on that, and we should be able to do all that kind of little bit, walking that extra mile. And if that is done, I think sometimes goals are also made to activize the machinery. Goals are not actualistic. So if we think that we will be able to eliminate tuberculosis by 2025, we are not going to. But by doing that, what has happened? The Honorable Prime Minister is directly monitoring the TB program. Number two, all the medicines which are so expensive, like bedaquiline, costing 1.5 lakh per month per patient, made available free of charge. Delamide available free of charge. If the patient comes to our DRTB clinic in our Mumbai, and I need that person to be treated with bedaquiline, I just called BMC. Within 4 hours, I get bedaquiline. So that much has been done. If I need to, I cannot put a financial burden on a patient. TB PCR to be done, that to be done. We just take a swab, send it to the BMC clinic. Within 2 hours, 3 hours, we get report. So that much facilities have been happening because it is a target or deadline that we need to eliminate. So we will be able to achieve something. And whenever we make such deadline, they are always extendable deadline. And they can be extended by 2 years, 3 years, or global deadline is 2030. But the whole world is watching us, because if today either WHO or UNAIDS or US government or anybody making any deadline, they are making on the strength of India. If all the deadline minus India, no deadline will be completed, whether you talk about HIV, malaria, tuberculosis, or many diseases. So all this strength of India has to be positively or constructively utilized. And that strength of India is always going to remain a core of India. So that not only for India, we are going to help the rest of the world, particularly those which are below the poverty line countries.
Thank you for your very encouraging words, Doctor. Although you have spoken about this throughout your talk, but what does putting people first mean to you? That is the theme of AIDS 2024. What does it mean to you?
In HIV, there are a lot of terminologies which are old terminologies, but the terminology name has been coming now. For example, post-exposure prophylaxis. I have been doing post-exposure prophylaxis for syphilis for 35 or 40 years. Post-exposure prophylaxis for gonorrhea, chlamydia for 35 years. But we didn't need the term post-exposure prophylaxis. I remember I started working with the sex workers in the red light areas. And in 1982, I realized that calling them whores or prostitutes is a demeaning. So we introduced a term called women in prostitution, girl in prostitution, child in prostitution. So here the person is first, condition is later. Similarly, same philosophy is used here, that when you say you address a person, you don't address as AIDS patient or HIV patient. You say person living with HIV, people living with HIV. You do not say comatose patient, you say person in coma. So that way the condition is secondary, and here is centric to patient. Secondly, these are only word play, and we should introduce that word properly. But at the same time, when you go in action, for example, during 1992-93 riots in Mumbai, the communal riots, and we were already working in the red light area where we were going with a batch of condoms. The sex worker said, "Doctor Saab, please give us some food. We are dying of hunger. The HIV will kill us 20 years later." So if I don't have a option in my mind about people first, then I would say, no, my job is only condom. I will only give condom. I don't do anything. But no, we stopped that. We approached 2-3 industrialists. We made khichdi. We got pav, and we distributed for 20-30 days in the red light area only khichdi and pav and milk powder. So we realized that what is important now is saving their life, and then we have to save them from HIV. So there are some examples where we need to always categorically tell what we are talking about. And therefore, PLHIV, there is nothing like a AIDS patient, so we should eliminate the term AIDS. We should always call PLHIV or child living with HIV or women living with HIV. And secondly, even that HIV, sometimes it is a stigmatizing term, because everybody by now knows that HIV is stigmatizing. 30 years before I started clinic, Unison Medicare, 30 years before I had that vision that if I call my clinic HIV clinic, it will have a repercussion. Even before I could start the clinic and started doing my interior work in the clinic, all community people came and they made a complaint to municipal corporation that he's a HIV specialist. He will get all his HIV patient and will be all at risk. So my clinic work was stopped for 2 days. I needed to go and explain to those officers that look, I'm very much conscious of not spreading any kind of infection. This chance is HIV. But we never called it AIDS clinic. We called always Unison Medicare. And we didn't want to boast that we are the best. So Unison is apt clinic. So that way, if you introduce some terminologies where I will just show you, we maintain two case sheets. One case sheet is called green case sheet. Green is the hara in Hindi. And blue case sheet is called Neela in Hindi. Hara means HIV. Hara, HIV. Neela means non-HIV. So as soon as I see the case sheet, I know that the person is HIV positive, the other person is not HIV positive. I and my staff don't have to tell person that you are HIV positive. Secondly, by your action, I don't use gloves when I examine patient. I don't use mask. I give a pad to them. I hug them. So that gives them example that this doctor, despite not related to us, he has no scare. So why should we related people, brother, sister, mother, father, we should discriminate the person? So your action should speak about that person. And therefore, when you put starting everything as a person-centered approach, for example, sometimes when the people come, I always tell them that look, because I'm a HIV specialist, because I'm an infection specialist, I will take side of my patient. I will not take your side. And you also should be considered that among 4 or 5 of you, he is the unlucky one who got, or she is the unlucky one who got. You also treat that person with some kind of honor and dignity. And that example, another example I can give you. One of my patient, almost 25-30 years back, daughter-in-law, mother-in-law discriminated her that she is keeping my clothes separately, she is keeping my children away from me, I have to cook my own food. So I said, how do I solve this problem? It is not pep talk will solve the problem. I said, look, I will visit your home. I visited her home. When I visited her home, I asked her to make a tea. Her mother-in-law said, "Hey, Doctor Saab, you know she has AIDS." I said, "नहीं, इसीलिए बोला उसको बनाने दो चाय." So that way, when she made a tea for me, that sent a message. In my clinic, I have one attendant who is with me for 24-25 years, who is HIV positive. For me, that is example. She is more sincere than other people. I have one lady who is a Devdasi turned sex worker and now reformed and working with me for 30 years. So these are the example I keep, and I tell people that you don't have to do a lot. Whatever a little bit you can do in your own way, that's good enough. And that is destigmatization, giving them financial rights, giving them empowerment, and that is more than enough.
Yeah, so you are an example of example is better than precept. So what you say, you do, you show it by example. That is important. That is, I think, what is means people putting people first. Dr. Sir, just before we end, your message for AIDS 2024. You will be an important part of that conference. What's your message for it?
You see, AIDS 2024 or whatever AIDS conferences are happening, they are all happening except India, anywhere in the world. And I have been telling the International AIDS Society and international community that look, number one, India is number one in population. Number three in HIV positive people's population. Number one in ART supply. 92% of the people with HIV, they are taking Indian medicine. And if you think India about 10-20 years before that we didn't have facilities, you come and I'll show you at least there are 4-5 centers in the country which have much better and greater facilities than anywhere in the world. So under that kind of situation, I don't know why we are stuck in getting the conference in India. And if we don't get, then it will never come. So we need to keep on fighting. So AIDS 24 is important. People first is important. Person first approach is important. You see, there are small countries, not even more than the size of our states. They got conferences 3 times, 4 times, 5 times, each country. And we are a huge country, we are not able to get it. So we need to impress upon our government. We need to impress upon our machinery that look, we need to do proactive work to see that the conference comes to India. Whether it is a major conference like this even year conference, which has 15,000 delegates, or odd year conference, which is the HIV science conference that gets 5 to 7,000 people. We need to get it. It is immaterial whether it comes to X, Y, Z city. It's immaterial whether I'll be part of that conference or not. But we should get the conference in India. And I think my role this time also will be the same. Working over there, negotiating with people. I keep on doing that for the last several years. And my whole purpose of being in International AIDS Society was initiated only because I wanted to bring conference one day to India.
And hopefully you will, sir. We are with you in that mission. We are all with you for that. And thank you, sir, for such a candid sharing of your thoughts. And thanks to our participants and listeners also. I'm sure you enjoyed this very, very enriching discussion. Friends, we were listening to Dr. Ishwar Gilada, an HIV expert, Governing Council member of International AIDS Society, and President-Emeritus of AIDS Society of India. And above all, a very caring and upright human being. Thank you for being with us today, Dr. Thank you.